Dr. Wilkoff, thank you so much for being here. I'm so looking forward to this conversation.
It's always exciting.
I found a beautiful article that you wrote in Medscape, and I am so excited because I reached out to you to talk more about this article, and you wrote back, and here you are. So thank you for your time and for being willing to share your expertise.
Well, I'll try. I don't know how much expertise I have left, but I drag it out. So,
And tell everybody a little bit about yourself. You're quite an experienced pediatrician. You've done a lot of writing. Can you expand more on all of your accomplishments?
well, I found Maine because my wife is a native Mainer. And once I finished my training and fulfilled my military obligation up here in Maine, then I began in practice and have been practicing here since the mid 1970s. Just a general pediatric, rural, suburban practice. And it was a lot of fun. And I made enough time to do some writing books for parents that I thought shared information that they might not have been getting elsewhere. And I was lucky enough to get four of those published. And around the same time, I also had the opportunity to start writing a monthly column for Pediatric News, which is a tabloid that gets sent to most pediatricians around the country. And I've been doing that for 30 years. And that's it. The writing was fun and it got me a chance to travel around the country a little bit beyond the Today Show and just stuff like that. But I found actually, in retrospect, that if I can't see the family in the office with me, the books are only a little bit of help because there has to be a give and take. It all has to be nuanced. And so for those of us who write, I could make it sound very straightforward, and that just doesn't cover it. It has to be nuanced.
I do agree. There's such a difference in real life when you're talking to families. Every family is different. The advice that you give to families depends on who you're talking to and what their situation is like. So I find that as well. So my podcast is called Your Child is Normal. And an article that you recently wrote in Medscape caught my attention where you talked about the Rumpelstiltskin effect. And I love this. I love this analogy. So can you describe what you were talking about when you referred to the Rumpelstiltskin effect?
I think first off, you have to start with the reality that we all are uncomfortable with the unknown and uncertainty. And if we're sick or our children are sick and we know what it is, it's strep throat. You went to the doctor and he or she said it's strep throat and you've been there, done that, you know what comes. But if you go to the doctor with a problem and he or she doesn't have an answer, once is okay, maybe wait, it'll get there. But eventually it gets very scary and very uncomfortable. And you start looking for all sorts of different options and explanations. And the bottom line about the Rumpelstiltskin effect is once the doctor can give what your problem is a name, a high percentage of that concern melts away. It's a feeling of relief. And just to remind you who he was, Rumpelstiltskin was a terrible old man. Nobody knew his name, but he kidnapped the queen's daughter and wouldn't release her until the queen could guess what his name was. And it was a terribly difficult name. It was Rumpelstiltskin. And she exhausted every possible avenue to find the name out. And she finally succeeded just at the last moment. She said his name and the spell was broken. The child was returned and the whole kingdom lived happy ever after. So that's what the Rumpelstiltskin effect is, that there can be a tremendous relief when you get a name for what it is you have. And the reason that's important is that there are lots of reasons. It means that you have a name you can share with other people and they'll have heard of it or they can look it up and will have heard of it. And of course, it may lead you to a cure or a remedy for your problem. But even if it doesn't, sometimes you're relieved just to know that's what it is. And eventually it can open up a whole avenue of similar sufferers, a tribe that you can join, whose children also have that same problem. It may open up research opportunities if there's no cure right now.
I agree. A sense of community is a very calming, reassuring feeling. If you can talk to somebody who has the same problem or who can relate to you, that can feel incredibly relieving.
Right, exactly.
As a pediatrician, I'm sure you can relate to this. I'm thinking about the variety of rashes that I've seen over the years. And there's so many rashes that you look at them and you know that they're okay. You know that the likelihood of it going away is very, very high. But you also know that a parent is looking for the name of it. And I think the reason being, you're exactly right. There's comfort in knowing what it is. And so I don't know if you can relate to that, but there's so many pediatric rashes where I always am happy if I can give them exactly what it's called just for that purpose so that they can feel better when they leave the office.
Interestingly enough, many, many, many years ago, there was a rash that began to be seen, or at least written about, and I can't remember. It was unilateral, just one part of the body, and it didn't scar, it didn't last, it barely itched. And somewhere along the line, I saw a case or heard about it, and I started to see more of it, but it didn't have a name. And so, at least locally here in Brunswick, Maine, I told everybody that this rash doesn't have a name. And because I'm sort of an egotist, I'm going to call it Wilkoff's rash. And so, in a very small 20-mile radius, that rash was known as Wilkoff's rash. And I taught my coworkers how to identify it and what to call it. So it was such a nothing rash. It didn't cause much relief, but at least I had given it a name. So
I'll bet your patients did feel some relief just by you calling it the Wilkoff rash. So
yeah,
that was very smart of you.
yeah, yeah.
Where I feel torn as a pediatrician is I agree that there is benefit to finding a label because of all the reasons that you mentioned. It gives parents clarity, it gives them validation. I think also it can give parents access to services. Why do you think that labels feel so important for families today?
Well, as you're probably aware, there is a very high anxiety level in this country and maybe the world all around, and certainly in parents. And so I think we're all a little more concerned than we used to be. And you layer that anxiety on a bit of unknown, that has a compounding effect.
In your opinion, as a pediatrician, do you feel like there's more anxiety today than in previous years?
Oh, huge, tremendous. And some of it is because people are having less children and they can focus the little anxiety that they may have had for one, for several children spread out. It focuses on one child. I think it's hard to know where to look for resources, particularly if families have spread out all over the country. Your parents might not be there to rely on, or maybe you don't trust them because they're in the other world and there isn't a traditional family way of doing things in your family. So that gets lost. And there's so much information out there. I had one parent talk to me, about 2 months ago, talked about when he found out what I had done in my previous career and that I'd written books. He said, there's just a fire hose of information for any parent who wants to read about things. And that's nice in one way, but there's just too much. You don't know how to pick or choose what the better advice is.
It's a fascinating paradox because, on one hand, we live in an era where there's information at your fingertips at a second's notice, at a millisecond's notice. You can find anything you're looking for. So you'd think it would bring parents more relief and less anxiety. But I agree with you. We're living in an era where it's just the opposite. People are more nervous than ever.
Right, right.
So bringing back to your article, what I really liked about it was you touched upon two ideas. One is the idea that a label does provide relief, which I agree with completely. But then there's another side to finding a label. And sometimes a diagnosis can come with some risk, it can come with some struggle for a child. And can you explain that perspective as well?
Yeah, I think there are a lot of downsides, or certainly some big downsides to getting the diagnosis. And one that doesn't probably get enough discussion is the diagnosis could be wrong. Not only did you want a diagnosis, but your doctor wanted you to have a diagnosis as well. And the longer your relationship dribbled on and you weren't able to give that diagnosis, you're becoming a failure. You don't like to be a failure. You may be uncomfortable yourself. So you may start looking at options that are close enough to the patient's symptoms, but not completely. So you reach for that. And either you give the child that label yourself, or you refer them to someone who is alleged to be an expert in that problem. The problem with that is that by sending someone to someone who specializes only in X disease, they unfortunately, unless they're not careful, they have a bias that you walk in, they're immediately thinking, oh, this is another child with X disease. I know this. And so they turn a deaf ear to those parts of the symptoms and signs that don't quite fit, but let's run with it anyway. And so, A, the diagnosis may be wrong. And second, the diagnosis may change. Even with everybody's best guess, you may only have a mild case and it gets better. So that's the first thing.
I like that you touched upon this because this is, I think, something hard for pediatricians in general because we're the front lines. And so oftentimes I'll have parents bring up behavioral concerns about their child, and the behavior concerns sound relatively normal and okay. And you know that the child with some support will likely outgrow it. But then if they carry on and go to a specialist and they get a diagnosis, let's say they're on the spectrum, and then they come to you and sort of imply that maybe you missed the diagnosis. And it's an interesting song and dance because we're all looking out for the child. We're looking for their best interests. And sometimes I can tell parents want a diagnosis. So that's what's tricky is you want to reassure them. You want to let them know their child's going to be okay. But also there is this label conundrum where they're
Yeah.
seeking something, which to your point carries some risk with it.
Yeah. Well, just as an aside, it was probably more than 40 years ago, given the age of my children, when I married into my wife's family. There was one Thanksgiving we were at the other side of the family's house and we were deciding where people were going to sit. And one of the 9-year-old niece or nephew said, I'm going to sit next to Doctor I don't know. And I said, well, it turns out after a little bit of ferreting around that the reason I was called I don't know on that side of the family is because 80% of the time when they asked me a question, I said I didn't know. And most of the time I didn't know, but some of the times it's just the explanation was going to be so far out of your sentence. And that also reflects a little bit about how I operated in my practice. And every now and then I'll run into families in a grocery store and say, oh, Dr. Wilkoff, you was great. And one of the things they like best that I hear about me is that I was not afraid to say I didn't know. And that's a hard thing to do, but the better you get at saying I don't know, the more valuable your advice is when you say I do know. So that's just an aside that I think fits in the picture as well.
I think that shows some humility on your part, to be honest. If a doctor said that to me, that would make me feel reassured because I think as an experienced pediatrician, you know when to worry. So if you're saying you don't know in a tone that's not concerning, that would provide relief for me.
Yeah. Yeah. Well, I think the second part of that is not to just drop that and walk out of the room, but I think you also say, I don't know, but we're going to help you find the answer together.
I always like to tell parents when to worry. You could say, I don't know, but if this symptom pops up or this happens or your child acts in this way, let me know, come back. We'll talk more. We'll find an answer.
To carry on with the direction we were going before is the self-fulfilling prophecy bit, the accepting the diagnosis as who you are. It becomes your identity. There may be a fair good side to that, but mostly it's a bad downside. Just for an example, how would you introduce your child to someone else? You say, well, he's an asthmatic. Well, it would be better to say, this is who he is and he has asthma. Because if you, as soon as you say asthmatic, that sets up a whole bunch of expectations, not in the person you're talking to, but in the child who then sees himself primarily as an asthmatic or a diabetic. I mean, it's just semantics, but it shows there's a child there that's beyond the diagnosis, that's beyond ADHD, that's whatever. So I think that's an important distinction that needs to be made. It's simple as picky eating. Here we're talking about older children who are picky eating. I mean, the little kids are all picky eaters, but if you're 7-year-olds and still described as a picky eater, then that's what you're known as in the family. That's what becomes special about you. At Thanksgiving, you're Luigi, the picky eater. And If you venture into eating some new different food, that breaks the spell. You're no longer Luigi the picky eater anymore. So,
And I think self-confidence in a child matters so much. There's so much value in feeling good about who you are. And if in your head you're ADHD William, as opposed to William, who also, by the way, has some ADHD characteristics, I think a child's at risk for thinking of themselves in a negative way.
right.
So I guess my question is, should we as pediatricians be doing something differently? Because as we talked about, we're trying to decide, should we name something? Should we step back and watch? So how do you personally approach that decision in your own practice?
But before we move on, I think the deeper, better answer to that is that, for the person who has a solid diagnosis, we know they're diabetic, we know they have juvenile rheumatoid arthritis, then you want them to move beyond that identity, accept it as a problem, but move beyond it and do it. But from the standpoint as we as pediatricians, I think there's a lot we could be doing and a lot of stuff we've been doing wrong. And here it comes with what I would call soft diagnoses, diagnoses that aren't cut and dried, that there isn't a lab test or an X-ray or whatever. These are just observational things. Highest among that is ADHD, which didn't exist when I started in practice. There were, a handful of hyperactive little boys, no girls, little boys. And after a while, people began to say, well, there's some distractibility here. And then stimulants got into the picture, and which could maybe treat the problem. And then it just took off. And ADHD is a phenomenon now. It's not a really solid diagnosis. There are people who will disagree with that, but I think it's more a description of some behaviors. And there is some of it, I'm sure you're born with some of it, but a lot of it is just a function of being overtired or being raised in an environment that doesn't suit your personality, and then you behave that way. But to lump it all together as ADHD, I think we've done a poor job of that. And we've reached too soon for medication that maybe works and maybe doesn't work. And that's compounded the problem. In that same category are chronic fatigue syndrome, prolonged concussion symptoms, things like that, that we don't have a real test for. So if we are chronic Lyme, those conditions clearly exist. But under those umbrellas are a bunch of kids who are people and adults who don't have that problem, but who have been given that label because it was convenient and seemed to be a best fit, but it wasn't the real fit. And I think we as physicians have to do a much better job of questioning and saying, gee, is this really the right diagnosis? Are there other things that could be causing this? And I don't think we are. So
I want to go back to what you just said about how when you first started practicing, there wasn't the diagnosis of ADHD. I know that there's been a tremendous increase in the diagnosis and label of ADHD, but you really didn't see any at all? That's so interesting to me.
no, I mean, I obviously in retrospect, knowing what we know now, I said, oh yeah, some of these hyperactive kids also were distractible and had short attention spans. But no, I can remember giving a little teacher's workshop to a bunch of teachers and saying, I'm just reading this stuff now, and that these kids who are hyperactive, it doesn't make sense. But if some physicians have given them stimulants, they settle right down. And I wouldn't give my own child stimulant, and I don't want to hear about this. Within 2 years, I would bet, I was getting calls from parents who said, my teacher has read something somewhere else or talked to other people, and gee, they say if you give Johnny Ritalin, this is going to make things better. And from then, I had to go back and say, okay, listen, this may work. And if we're going to do it, this is how we try it. But I was very hesitant to do it. I still have always been very hesitant to do it. But it's amazing how the whole thing just flipped over and it just took off. But you have to be an octogenarian to have seen that. And that's why you talk to a lot of people my age who just say, where was that all over? It just wasn't there. Well, clearly something is there now, but how much is it as a function of how our society has changed, our sleep habits have changed, our screen time has changed, all that sort of stuff. That's some of the problem. That could be the answer. So,
I'll read about some communities where the rate of ADHD diagnoses have tripled in the
right,
last 20 years.
right.
And there has to be more to the story than just more kids are being born with ADHD. Has
Yeah,
to be a
exactly.
function of environment, how we're
Right,
diagnosing them, et
right,
cetera, et cetera.
right. Yeah, that's tough.
And I agree with you. I clearly see a lot of kids in our practice that improve, like their symptoms improve with the stimulants, and now it's considered to be first line as treatment for children that are diagnosed with ADHD. But I do agree that as pediatricians, we should be giving a lot of thought to that diagnosis because to the first point we made, it gives parents relief and it makes them feel better when their kid has a diagnosis and some potential direction to help them feel better. But it can also come with downsides.
Right, right.
And I'm curious, do you have any ideas as to why we've become this overdiagnosis culture and why we're overlabeling kids?
I think it's easier. The other management options are time consuming and not flashy, and you can't sell them. I have a overriding passion, some would say obsession, that sleep deprivation is at the root of all evils. You name a condition, your child sprains his ankle, I'm going to say, if he'd been going to bed earlier, reflexes would have been sharper and he wouldn't have turned his ankle. I mean, I can sometimes get that far out. But helping a family managing sleep deprivation is time consuming. What do you sell them? You're not going to sell them sleeping pills or mattresses. That's just one example how we just are reaching for the easy thing. And we're taxed with the sheer number of mental health and behavioral issues that you just don't have the time sometimes to sit down and talk about sleep and exercise and those things that are all really important. So,
There's a line that's if we could recommend one drug to kids, one drug and one drug only, that would make the biggest difference. It would be sleep.
exactly, exactly.
Everything is better with more quality sleep. And I
Right.
think there's a lot against kids these days because it's harder and harder to get good sleep because everybody lives such busy lifestyles. We're competing with screens, the high tech around us. It makes it harder to make more melatonin. We're not as sleepy at night. There's just so much going on. Kids have FOMO. They don't want to be missing
Yeah.
out on anything.
Right. Right.
And it's harder to calm the brain down and then therefore harder to get good sleep. And so I agree with you. My
As
mom always says that too, by the way. Sleep is the best
exactly.
medicine.
Exactly. I learned 80% of what I learned was from my mother and not from medical school. I mean, that's the truth, really. Anyway, one of the things that popped into my mind as I was mentally wondering about what we were going to talk about is autism as an example of a labeling problem. And back before ADHD, there was retardation, which was a very good word. Retarding just means slowing down, that somebody had been slow. And we talked about mild retardation, more medium retardation, and severe. But somewhere along the line, retardation became a bad word. It had taken a bad turn, and I'm glad that it's gone. But it left families whose children had developmental difficulties there without a name, without a label, except in rare situations where it was a genetic something or other. But otherwise, it was difficult to say. And back again, when there weren't ADHD kids, there were autistic kids. If you told me I was going to see a child in the office who has autism, I would say, okay, I'm prepared for the child doesn't talk. That was what autism meant back then. But after a while, again, more was learned and became, well, there are kids who talk who have this problem playing that ping pong of language that we all fortunately can do with each other that these kids can't do. They can't interpret what you're saying well, and it's sometimes hard for them to express it as well. So then the umbrella of autism has expanded. And unfortunately, well, fortunately, it's given these families of children who are developmentally challenged or disabled, it's given them a label that people understand. They're not embarrassed to say, my child has autism. Autism, you have some understanding and sympathy for what they're going through.
In your opinion, parents are very concerned with all of the number of kids that are now meeting the autism diagnosis. The number keeps getting higher and higher. But I do think that some of those kids that were labeled as slow or mentally retarded are now in the diagnosis of autism, which is accounting for
Exactly.
some of the increase in numbers.
A huge percentage of them, exactly, because it's not an un-PC thing to say. It's much easier, and it's helped those families get help and care. So what if those children don't fit you're in my stricter diagnosis of what autism is, that it's at least they're getting something.
Right. And to your point, they get services covered, which is very helpful for kids.
Right,
That can be a benefit to a label.
right. But on the other side, or a different side, is that there are parents now of children who are severely challenged or disabled who aren't getting the services they should get because we've lost the severe autism thing. The kids who were severely mentally retarded, those parents are saying, look at us. We're a separate group from this whole big expanding group that is less challenged, maybe.
Yeah, I find that when parents often are concerned about the rapid increase in the autism diagnosis, and they worry understandably so about their own children. But I have to say, in my experience, the kids that are truly autistic, where they're nonverbal, non-communicative, don't look you in the eye, can't hug and kiss their parents, it exists,
Right.
but it's very rare.
Right. No, I agree. And then there's the whole autism spectrum thing. For the older, mildly affected person with autism, they can look at that autism label as a positive, and I think many of them do, because say, listen, I'm not just, Louis who was a little weird. I have autism, and that explains some of my weirdness. And I'm rather I didn't have it, but it allows you to interact with me. I think that's a big help. Now, there are people who are on the spectrum who really would rather not be labeled as on the spectrum. So it's a very individual thing. So before you hand somebody that label, say, okay, this is the baggage that comes with that label. You can pack it or unpack it, or let's work together to figure out how we want to market you or package you so that you can feel better about yourself and get the services that you want to. And I'm afraid spectrum is going to become a word that is going to be a bad word. Spectrum is a word we should be using much more with every illness to say. There's a whole spectrum of diabetics. There's a whole spectrum of asthmatics. And we need to do better about describing that. But to just throw around, well, he's on the spectrum. You don't have to even use the word autism. People automatically, I know what we're talking about. So
To your point, it sounds like a lot of this should be a nuanced conversation and an individualized conversation.
exactly,
I'm also
exactly,
thinking a positive about labels with my own kids. If there's a child that's acting a little different, if I say to my own kids, oh, so and so is on the spectrum, I can see the light of a sympathy turning on in my kids' heads,
exactly.
that it's not their
Right.
fault. And I can see that my kids will think about that child in a different way. So that's a positive to a label.
Exactly. Exactly. Yeah.
So what resonates with me is the idea that we don't want to define our kids by their problems. So, for parents that want to approach this thoughtfully, for those parents whose kids have a diagnosis, do you have any advice for them on how they should talk to their kids, how they should raise their kids, or how to think about it in general?
Well, I think it's going to be difficult because as a parent yourself, you worried and the child and the illness has been a total focus for so long or with so much concern that it's hard to think past that and think more broadly. So I think acknowledge that it's going to be hard for you to do that. But I think the best part, I always think the best way to parent is parent by example. And I don't think that gets enough emphasis as well. I mean, you don't teach manners to a child. You don't teach good behavior to a child. You exhibit it yourself, and then you hope that most of your kids will follow it. And it's not a guarantee. So anyway, start a good example by yourself, not the words you choose about describing your child and how you spend your time and how the family focuses their time. And try to build a life beyond that diagnosis for the child, whether it's other activities or playmates or acquaintances that aren't familiar with the diagnosis or aren't totally locked into it. I think building another life that makes the diagnosis just a part of it. No argue it's going to be a big part, but try to make your life that's substantial.
I think that's an excellent point. For example, an ADHD diagnosis, parents will ask for advice on what to do with their children. And people have limited time. We have limited resources. And some parents will ask about seeing a behaviorist, for example, or going to a psychologist, which is all great. I'm not saying that's not a beneficial use of time, but I think probably even better, in my opinion, is to have that child find a sport or an outlet that can help them get their energy out and can help them socialize, but in a way that they're not defining themselves by their diagnosis. For example, if you get a kid with ADHD symptoms who is in karate or who's a swimmer and they can succeed at that, they're not leading by their diagnosis, but it's something that will also help them.
Right, right. And I think there's a whole skill in that. And I think of advising parents of what activity to choose. And you and I may guess the wrong activity right off. If that doesn't work, let's try X instead of Y. I don't know whether those people would be occupational therapists or what you would call it. It may just be experience to say, well, this is the child's symptom complex. This is their strengths and this is their weaknesses. Do you have a suggestion of what activity they might do better in, or what kind of coach might handle them better? That sort of stuff.
Yeah, and I think that would be one way for parents to make sure that their diagnosis is more of a tool for the child rather than their identity.
Exactly.
Okay, so I think this is really helpful. I think acknowledging that a label has some benefit, but also just in our own minds, we don't want to overemphasize it. We don't need to over discuss it with the kids because there are some detrimental aspects to overthinking about it, to overemphasizing it.
As you're relating that, I was just thinking, I bet if you had somebody sitting where I am who was a pediatric cancer specialist, they would say, oh, we've got an office for that. We're doing that already. I think you see that happening in children with cancer. You hear about all the different things that they're being involved in and trying to move beyond their diagnosis. Somehow the oncologists have been aware of that for longer than we have. So,
Yeah, you got to have some fun with life, right? You can't just
right,
dwell on your
right,
labels and your illnesses and your
right.
challenges. You want to have a good time too.
Yeah, yeah.
I really, really appreciate your perspective. I can tell you're such a thoughtful pediatrician, and it's really been a pleasure talking to you.
Well, thank you. It's been fun.
It's been a lot of fun. All right. And for parents listening, tell them the books that you've written. So if they want to learn more from
Um,
you and learn more from your expertise.
Well, I'm a little cautious of recommending the books. They're 20 years old, but they deal with topics that are good. But the one probably I feel best about recommending would be the one on coping with a picky eater. I think that has the best advice in it. It doesn't need to be nuanced. The book that has been the most widely published is How to Say No to Your Toddler. It's been published in Russian, Polish, and Italian. But I will be right up front that I think that timeout is probably the most efficient bottom line if other things aren't working. So a lot of people will look at the book and think he's one of these lock them in the room guys. But the whole first two-thirds of the book talks about what you can do to create an environment so you don't have to say no as often. And when you do say no, it works. And I think if you follow that argument, if you're lucky, you won't have to even think about timeout. And you could modify the timeout, just sit in the room with the child. But I'm a little hesitant to recommend it without it blowing up in my face. But um, and
You're all right. I was in timeout plenty of times in my childhood, and
but
I've
the
moved on and I've forgiven my parents. So
the breastfeeding book was called the Maternity Leave Breastfeeding Plan. And it immediately went right on to the Leche League book of recommended books. And clearly no one in the league had ever read the book because I've come out just saying, not everybody can breastfeed. It's not that easy for people. And here I'm going to give you suggestions on how to have your highest success from what I know as a man who watched thousands of mothers breastfeed. But I'll be there for you if it doesn't work out for you. We're going to help you be the best parent you can be. And as I said in the most recent Medscape column, breastfeeding is not a course taught as a pass fail. So, and then
Wow.
sleep, there's a book about sleep. And if I had to rewrite it, there's so much more support for my position that it's not in the book. So,
Well, what a beautiful career you've led, and it's been so wonderful to learn from you and hear your perspectives. And thank you so much for your time.
okay, well, thank you. And call again if you just need to chat, record it or not.
I'll take you up on that.
Okay, bye-bye.